Treatment and management of ARDS. Since ARDS is a syndrome rather than a single disease, treatment is primarily supportive, focusing on lung protective mechanical ventilation, fluid management, oxygenation strategies, and treatment of the underlying cause. Starting with mechanical ventilation, which is a lung protective strategy, invasive mechanical ventilation is required in most cases due to progressively respiratory failure and refractory hypoxemia. Key principles include low tidal volume, 4 to 6 milliliters per kilogram predicted of the patient's body weight, reduced volotrauma by preventing alveolar overdistension. Then there's positive end expiratory pressure, which prevents alveolar collapse, also known as atelectasis, and improves oxygenation by keeping the alveoli open. Moderate to high PEEP is used in moderate to severe ARDS. There could be permissive hypercapnia, which allows higher CO2 levels, reducing barotrauma, but requires a pH of greater than or equal to 7.2 for patient tolerance. Plateau pressure, less than 30 centimeters of H2O, prevents excessive lung stress and reduces ventilator-induced lung injury. Then we have prone positioning, improves ventilation perfusion matching, redistributes lung perfusion, and enhances oxygenation by reducing dorsal lung compression. In severe ARDS, advanced ventilatory strategies such as airway pressure, release ventilation, or high-frequency oscillatory ventilation may be considered. In refractory cases, extracorporeal membrane oxygenation provides temporary oxygenation while minimizing ventilator-induced damage. Now we have some oxygenation strategies. So the goal is to maintain an SpO2 of between 88 to 95% and a PaO2 of 55 to 80 millimeters of mercury, using the lowest FiO2 necessary to minimize oxygen toxicity. High-flow nasal cannula or non-invasive ventilation may be attempted in mild ARDS, but early intubation is preferred in worsening cases to prevent further decompensation. We could do inhaled pulmonary vasodilators like nitric oxide or prostacyclin that can be used as a salvage therapy for severe ARDS with pulmonary hypertension, though benefits are temporary. We can treat with fluid management or help with fluid management. Conservative fluid strategy like goal-directed diuresis is preferred to prevent pulmonary edema exacerbation, especially in non-shock ARDS. Liberal fluid resuscitation is only indicated in cases of septic shock or hypoperfusion. Balanced crystalloids like lactated ringers or plasma light over normal saline to avoid hyperchloremic acidosis and acute or just kidney injury. Now we want to treat the underlying cause. Sepsis-related ARDS will treat with broad-spectrum antibiotics with source control, like an abscess drainage. Aspiration ARDS will avoid gastric contents aspiration, initiate antimicrobial therapy if pneumonia develops. For trauma or transfusion-related ARDS, we can do or just optimize in general hemodynamics and minimize further transfusions. For COVID-19 or viral pneumonia ARDS, we can provide supportive care and antiviral therapy if indicated. So for pharmacologic support, we can do a neuromuscular blockade like NMBA. An example would be cistracurium, which is used in severe ARDS to reduce patient ventilator dyspnea and oxygen demand. We also have corticosteroids like dexamethasone that can be considered in moderate to severe ARDS, particularly in early inflammatory phases, through data remains mixed. However, prophylactic anticoagulation is another one for high risk of venous thromboembolism in ARDS, so patients require low molecular weight heparin or unfractionated heparin unless contraindicated. For nutritional and supportive care, we can do enteral nutrition like tube feeding within 48 hours to provide or prevent malnutrition-induced immunosuppression. We can do glycemic control to maintain our blood glucose, 140 to 180 milligrams per DL, to avoid hyperglycemia-induced inflammation. DVT and stress ulcer prophylaxis and LMWH, and proton pump inhibitors, PPIs. Early mobilization and sedation minimization in recovering patients to reduce ICU-acquired weaknesses. We have some advanced therapies for refractory ARDS. This can be extracorporeal membrane oxygenation, considered in severe refractory hypoxemia. ECMO provides extracorporeal gas exchange while resting the lungs. Adjunctive therapies such as stem cell therapy and mesenchymal cell transplantation are being investigated for lung repair in ARDS survivors. For the prognosis and long-term outcomes, mortality in ARDS varies by severity, ranging from 27%, which is mild, to 45% in severe cases requiring ECMO or prolonged ventilation. Patients who survive often have long-term pulmonary complications, including persistent restrictive lung disease, decreased exercise tolerance, and neurocognitive dysfunction due to ICU-related delirium. Pulmonary rehabilitation, psychological support, and gradual ventilator weaning are crucial for recovery. So ARDS is a life-threatening syndrome requiring rapid diagnosis, lung protective ventilation, conservative fluid management, and aggressive treatment with the underlying cause. The use of low tidal volume ventilation, PEEP, prone positioning, and advanced interventions like ECMO is crucial for improving survival. Early intervention and comprehensive supportive care will help reduce mortality and long-term complications in ARDS survivors.